Okay, well, I'm really delighted to be here. I'm the Associate Dean for Research in the College of Nursing, and I also am a professor in the School of Medicine, and I've been working there in the Osteoporosis Research Center for over 30 years. So I am passionate about osteoporosis, and I'm really here today as an activist, and I'm going to give you information, but I hope I can get you charged up to help me do more to address the epidemic of osteoporotic fractures that we have. So without further ado, I have no conflicts. My objectives, primarily, again, I'm hoping to stimulate your interest in addressing this epidemic, and I really think nurses can play a major role. And I'll talk more about why osteoporosis is really overlooked and frankly neglected. So then I'm going to still give you information, and I'm going to briefly review the things that you need to know, the definition of osteoporosis and what is an osteoporotic fracture. That's not a real clear-cut issue. Some of the epidemiology, the pathophysiology, screening, and the state of the science for treatment and prevention. And after that, there will be a test, okay? And I'm going to give you some resources for addressing this. So, you know, surprisingly, bone is a very active tissue, and it's undergoing regeneration all the time. Even after I'd been a nurse for over 20 years and I joined the Osteoporosis Research Center, I was surprised to see that bone is turning over constantly. That means old bone is being replaced by new bone, and it's being carried on in different sites across the skeleton that are called remodeling sites. And this shows what we call a resorption pit. This is all bone, and these are osteoclasts, the green little cells, and they're eating away dead or damaged bone. And they do this until they form this pit, and then signals are sent to these white cells that are called osteoblasts that come in and lay down new bone. And as I mentioned, this is ongoing in your skeleton all the time. One of these total cycles from resorption to completing filling in the pit takes about 4 months. And alterations in this process often account for osteoporosis, especially as adults become older and also around the time of menopause. So osteoporosis is actually a systemic skeletal disease, and it's characterized, first of all, by this microarchitectural deterioration in bone, and that is demonstrated here. These are electron microscope pictures of actual bone, and here we have normal bone. These struts are trabeculae, and they are what the skeleton's built on. It's kind of like the Eiffel Tower, has lots of struts to keep it up. Now on the other side, we see osteoporotic bone. And you see the trabeculae are much thinner. This one's in the process of being completely eaten away, and many have disappeared. And you can see if you were going to fall down some steps and you had this kind of bone, you'd be very apt to break at least one bone, if not more. So osteoporosis is also characterized by low bone mass. And the consequences are you have an increase in fragility and a very high risk of developing a low trauma fracture. So when we talk about bone mass, I like to talk about it across the lifespan. Bone health is really the issue. And you know, heart health, we're aware that that's important almost in infancy. And we really need to get to that point with bone health. Now, what this slide shows is across the x-axis down here in decades of age, and the height of these curves represents how much bone mass. So I'll start with this solid line, which shows the trajectory of bone mass across the lifespan in women. It starts increasing actually in utero and increases through childhood and adolescence, and right around the time of puberty there's a dramatic increase in bone mass. About 45% of the skeleton is put on. So that is our greatest window of opportunity, but most of you here are probably not pediatric nurses. So this continues up until about the age of 25 when peak bone mass is achieved. And after that, 25 is an average age, but once an individual reaches his or her peak, they don't gain any more bone mass. There have been studies trying to show that with exercise and diet and so forth, and there's really no significant gains to be made, but the important thing is maintaining it. Because here we're watching women again, about the time of menopause, they undergo a loss of bone associated with estrogen deprivation. As estrogen is lost, women can lose as much as 20% of their bone mass. And I'll show you a study that we did. So then after that menopausal bone loss that lasts about 6 years, women undergo slow loss of bone mass with aging, maybe about 1% a year. So depending on where they start with peak, they're going to fall down either, maybe they'll stay normal if they really had a high peak, or they may have low bone mass, which we call osteopenia, which increases risk of fracture, or they may fall way down into this osteoporotic range for bone mass, and they're extremely high risk of breaking a bone. So the dashed lines refers to men, and they have a similar trajectory, but they usually have larger skeletons and higher bone mass, and they don't go through a menopause, and in their andropause they don't actually lose bone as dramatically as women do, because although men lose some estrogen, it's not as dramatic because that's not their primary sex hormone. Now down here, this large dashed line represents individuals who don't have optimal environment, lifestyle, maybe they're ill, maybe they've taken medications, lots of things that can contribute to this. So they don't achieve an optimal peak bone mass. And as I said, you really can't correct that once they've reached peak. So those individuals we want to identify and give special care because they're going to be at very high risk of fracture. And I'll give you more details on that as we go along. So what is an osteoporotic fracture? It's defined as a broken bone or a fracture that's due to trauma equal to or less than a fall to the floor from a standing position. And that excludes the skull, the face, and fingers and toes. Now, sometimes this is a little hard to determine, but one message I'm going to probably hit more than once is I think we have to assess the circumstances of fall in our patients who come in with fractures. And both clinicians and the patients will say, well, anyone would have broken a bone if I had fallen. But let's say I came skating down here on a skateboard and ran into the front and fell over and broke my wrist. That would indubitably be a traumatic fracture. But if I walked in here and tripped because maybe there was a little glip in the carpet, walked in and tripped and fell and broke my wrist, that is an osteoporotic fracture. That is a low trauma fracture. And I'm going to talk about that a little bit more because we're ignoring his wrist fractures a lot. So fractures are common. 1 out of every 2 women over the age of 50 will sustain an osteoporotic fracture during her lifetime. Now, to put that in context, 1 out of 10 will develop breast cancer during her lifetime. Yet we don't hear that osteoporosis is such a big deal. But this is in women over 50. Men also get osteoporosis. We're kind of beginning to recognize a little bit more, but they're still, I think, overlooked. 1 out of every 4 men over the age of 50 will develop an osteoporotic fracture during his lifetime. And again, for a comparison, we use prostate cancer. 1 out of 3 will be diagnosed with prostate cancer. 2 million fractures occur annually in the United States that are osteoporotic fractures. And osteoporotic fractures are usually hip, vertebrae, and wrist. But there are other osteoporotic fractures, and again, it kind of boils down to the circumstances that caused the fracture. So this shows age-specific incidence of hip fractures from the Framingham study that they've been doing. They're following people for decades. And the point I want to make here is at what ages we see hip fractures increase. Actually, we see osteoporotic hip fractures in people under 60. They're uncommon, but it happens. Again, you have to look at circumstances. But people may have secondary causes of osteoporosis that cause them to have fragile bones at an earlier age. So this really shows there's a very, very slight increase in both men and women in hip fractures after the age of 60. It's very slow, but it does start to increase notably at age 65, and then it continues to go up. And of course, it's dramatically up after 85 to 90. So this is the point I like to hit home. I loved this article in the Omaha World Herald. It was on February 2nd, and it shows one of the volunteers at Methodist Hospital. She's 98 years old, and if I recall the article, she still comes to volunteer 2 or 3 times a week. And I think she's an example of how people are living older to an older age and are being very active and productive and having a good quality of life. But as I'm going to talk about a little bit more, having a hip fracture will most likely dramatically affect the life of an older adult who, they have other things that are compromised. But it would be great if we could prevent that hip fracture. And I think another key point to take home, osteoporosis can be prevented. Now, I went to nursing school a long, long time ago, but we were taught that all older people got osteoporosis. Every older adult would get osteoporosis. That is absolutely incorrect. We know better now because we've done a lot of research. So key point, osteoporosis and its fractures can be prevented. 20 to 30% of hip fracture patients die within a year after their hip fracture. Now, it's not the bone unless that hit a major artery or something when it was dislocated. But the morbidity that's associated with the surgery, immobilization, probably dietary. So they die of infections and pneumonia, etc. But the breaking point, that's kind of a pun, I guess, is when they broke that bone and had to undergo the immobilization and treatment. At least 25% require long-term nursing home care. Maybe today some could be cared for in their home, but they would probably need considerable help. So the other important fractures are the vertebral fractures. This shows a spine x-ray. And if you can see, these are normal, plump vertebrae up here, and the ones that are numbered are fractured. You can see they're compressed on the inner side. This side is pretty tall, yet they've been crushed. And a lot of times these break just from standing and walking. And other times, maybe somebody opened a window, lifted a grandchild. It takes very minor trauma to cause fracture. And these are not insignificant fractures if you've got one. Pain, chronic, acute. One thing that I've dealt with a lot of patients and some with severe kyphosis, which is that curvature. I've had patients that are bent over so far they have to look up to look at me, and I'm not very tall. I've had women, I remember one as young as 65 that had a severe kyphosis. It really affects your self-esteem. It's hard to buy clothes. And then it affects the digestive system, the respiratory system. It's just not a very good thing. And a lot of those happen silently. One thing I remember when I was practicing as a nurse, every once in a while you'd get a chest x-ray and you might see an incidental spine fracture, and we never paid any attention to that. But if you happen to see those, draw those to somebody's attention, because in any type of these osteoporotic fractures, if you get one osteoporotic fracture, it increases your risk for others. So it's not surprising that these fractures affect families. They have to provide care, either financially or personally, for these individuals who have at least temporary disability and maybe permanent. And these osteoporosis and its fractures are costly to the families. And also, recent data show it's the 10th leading healthcare cost for Medicare. So there are things we can do about osteoporosis at any point across the lifespan. And on the positive side, not surprisingly, calcium and vitamin D and weight-bearing exercise. Negatives that I'm not going to go into, but smoking and alcohol abuse have been shown by research to definitely affect bones. They impede the function of the cells. So I'm going to review calcium physiology a little bit because I think we just kind of talk about calcium supplementation and then don't do too much to encourage adherence. Calcium, of course, is critical for metabolic functions like the heart, muscle, nerve function, and the bone serves as a reservoir for calcium. Serum calcium is very, very tightly regulated. Now, the body depends on dietary calcium intake for its calcium source. And if the individual is not taking in enough calcium regularly in the diet, then calcium will be pulled out of the bones because we got to keep that heart beating and we have to keep our nerve function. And if you have a long-term dietary calcium deficiency, which you don't even notice anything is happening, but the bones are weakening as that calcium is pulled out. So the recommendations are shown here for calcium intake for different age groups. For most adults, up until about the age of 50, it's 1,000 milligrams a day. Over that, 1,200 milligrams a day. For reference, a glass of milk is about 300 milligrams a day. A lot of people don't like to drink milk. Dairy foods are still the best source. Cheeses, and there are a lot of fortified foods. Also, there are dairy foods that are lactose-free if individuals have a problem with lactose. We usually recommend that individuals try to get their calcium from their food. Because if you're eating healthy foods, you're getting other nutrients that you're not going to get if you just take a calcium pill. So on the National Osteoporosis Foundation website, NOF.org, there's a handy little calculator where an individual can calculate about how much calcium they get from their diets per day. So I recommend that to people who are really kind of anal or religious about getting down to calculating. It's really a nuisance to have to measure everything you take in, but we find people kind of eat in behavioral patterns. So if you kind of look at what you did for a couple days, you can get an idea of how much calcium you're taking in, and then supplement with pills. That's where we get the term supplementation. Everyone does not need calcium pills, but people who don't get adequate calcium in their diet should. Now, people ask me what type of calcium supplement to take. The type really doesn't make too much difference. We usually recommend leading brands, but you know, we've got so many available that are less expensive and more generic. The main things are to take with food. It doesn't have to be a full meal, but if you eat some food, it turns on your digestive machinery and then the calcium will be better absorbed. Also, distribute the supplementation throughout the day. We usually recommend, you know, morning, noon, and night so that you're constantly resupplying that bloodstream with calcium. Calcium phosphate is one good choice for maybe adults, especially some older adults who don't have a very high protein diet. Now, we used to say you have to test a calcium pill in a glass of water and see if it dissolves. You don't have to worry about that. Most preparations will dissolve appropriately. Now, one thing we encounter, and I think it's dramatized in the media, is that calcium supplementation causes heart attacks and kidney stones, and that is wrong. There are large, rigorous clinical trials that have shown that they do not cause calcification of the coronary arteries, nor do they increase the risk of kidney stones. Now, I will say that in individuals who are stone formers, you may have some who tend to form calcium stones. But there was even one very large study that looked at giving calcium supplementation to stone formers, and it decreased the incidence. What calcium does, it binds with oxalate in the gut, and oxalate is one of the things that stones are composed of. So in that study, calcium supplementation decreased kidney stone incidence in people who had a history of getting them. So put that one to rest. Now I'm going to switch to physical activity. That's the most important thing that can be done for your bones. During childhood and adolescence, physical activity will help to increase bone mass. What happens is, as children are developing and growing, their skeleton is adapting to their usual physical activity, so that when they get to be adult, they have a skeleton that can keep up with them. So if you have a real active child who's jumping around all the time and doing physical activity, they're going to build strong skeletons. But if you have a child who's a couch potato, the skeleton's going to say, I just need to be strong enough for a couch potato. So how much physical activity an individual gets up until the age of peak is critical. But after the age of peak, again, physical activity is critical for maintaining what you've got. So there are no research-based guidelines for how much exercise you need for your bones. So we usually go with the U.S. Preventive Task Force recommendations for physical activity in adults, and they say exercise regularly, at least 30 minutes every day. And recently, I'm not sure if it's U.S. Preventive Task Force or another group came out and said, you know, an hour a day would even be better. And work for bones means some impact on the bone. Walking is a great example, because when you move, they're getting some pressure that says, hey, we're working. Upper body racket sports are good, and that one's sometimes a little harder, but resistance exercise, even gardening, pulling weeds, anything you can do. Also, using the muscles does put some resistance on the bones, so keeping very active in a variety of exercises is good. So just lower body, walking, running, jogging, racket sports, resistance training. Now, swimming and cycling are excellent forms of exercise, and they do build muscle, but they don't impact the bone. So they can be part of a good exercise program, but they themselves are probably not going to maintain bone unless you're mixing your physical activity up with other things. Now, I think this is important when you're dealing with patients for teaching. Maintaining muscle mass is critical for older people, because losing muscle mass and tone contributes to falls. And falls are the major cause of osteoporotic fractures. So we need to think, if we're preventing fractures, we also have to work to prevent falls. And in our clinic, we try to guide our patients to physical therapy for programs, whether it's for prevention of, if it's for maintaining bone, prevention of falls, or helping with balance. And I think our physical therapy partners can do a lot to help prevent repeated fractures or first fractures in people who are at high risk. Also, balance is very important, because that's another reason people fall. Now, one thing about I caution individuals who go to the gym. A lot of older people are using the gym, and that's great. But I had a personal experience with a trainer who had me doing push-ups, pushing up the machines. And I said, I have low bone mass. I'm not sure I should be doing this. And he looked at me and he said, well, if it hurts, don't do it. And I'm thinking, if it hurts, I've just fractured a vertebrae. So, and it's recognized as a problem that not all exercise trainers know much about osteoporosis. So I think that's something, if you're counseling patients about getting physical activity and getting that upper body, to be aware of that. And so you can kind of maybe avoid those. Another real risky thing that I always worry about is putting heavy luggage up into the airplane compartment. There could be a study on how many vertebral fractures that's caused. So then one of my other loves, and I've done a lot of work in vitamin D, so I want to talk a little bit about the physiology related to bone. Now, serum 25-hydroxy vitamin D, 25-OHD, it's what we call the functional indicator of vitamin D status. So if you want to know your patient's vitamin D status, you order a 25D. Then there's something called serum 125-dihydroxy vitamin D, which is actually the active metabolite, and it makes things happen all over our body. So as far as bone, the indirect action of vitamin D on bone is facilitation of calcium absorption. In fact, you know, milk is fortified with vitamin D, so you get your milk, which gives you calcium, and you get some vitamin D. So you do need vitamin D to absorb calcium fully. But also, recent research has shown that vitamin D, both 125 and 25D, have direct effects on bone cells. So individuals, even if they have a real high calcium intake and think maybe they don't need vitamin D to absorb as much, they also need vitamin D to make sure their bone cells are functioning at their optimal level. Now, low vitamin D is epidemic in this country, and it's right here in Nebraska. And these are data from a study I did of nearly 1,800 women over the age of 55 in eastern Nebraska, and they were all living in rural areas, either small towns or out on farms. And what this shows is the distribution of values of their 25D. And you can see it's a very nice normal distribution, a normal curve. Some are low, some are high. But what was interesting is that 65% of them were below 30 nanograms, which is the minimum 25D that's recommended for optimal bone health. So we kind of think of women who live in the rural areas being outside more and getting sunshine, but 65% of them had 25D that was not high enough to support their bone health. And, you know, most of us aren't outside very much, so, you know, many of us are probably deficient in vitamin D also. Now, as you know, vitamin D is called the sunshine vitamin. The nature source is through sunshine. But there are a lot of things that work against that today. The darker the skin, the less vitamin D will be converted in the skin. And so it doesn't really have to do with race. It has to do with how much melanin there is in the skin. Also, during the winter months here, and that's usually from about mid-October to the middle of March. Now, I'm not sure it's going to run until July this year, but between October and March, we don't convert any vitamin D in our skin because the sun is so far to the south, and the angle of the sun does not hit right to turn on the vitamin D making machinery. In fact, one of my colleagues at Boston actually had a graduate student go out in a swimsuit on a sunny day and get sun for, I don't know, an hour or so. I don't know how long it was, hopefully not that long. But absolutely no vitamin D was converted. So the winter times we're in a dry period here as far as vitamin D. As we age, our skin converts vitamin D much less effectively. And the last point that affects almost all of us, sunscreen will obliterate almost all formation of vitamin D. If we use sunscreen according to directions, and there are good reasons to do that, you're not going to make any vitamin D. Now, some people recommend you go out without sunscreen for maybe 15 minutes at 10 o'clock in the morning and you can get some, but you know, it's kind of hard to measure that dose, and it depends on your skin tone. So you can see I lean towards supplementation, and I'll talk about that a little bit. So other factors that are associated with a low vitamin D that you might watch for in your patients is overweight and obesity. It's been shown in many, many studies. People who are overweight or obese have low vitamin D levels on average, and they need higher doses of supplementation to get them up to where they need to be. And the medications, particularly the seizure medications and the corticosteroids, also interfere with formation of vitamin D. Now, the recommended intake by the National Academy of Science is 400 to 800 international units a day. For most adults, 600. For older adults over 70, it's 800. In our research, we think that's too low. It may be adequate for bone, but there are a lot of other benefits of vitamin D because vitamin D affects almost every cell in the body. However, individuals will vary on how much vitamin D intake they need to get them to that 30 nanograms per mil that's needed for bone. And we've done studies on that, and we found actually there are genetic differences that will determine how much vitamin D you'll form after given a vitamin D supplement of the same dose. So you can't just take a certain dose or get a certain exposure and know what level of a 25D you're going to get up to. So supplements are very widely available. They're inexpensive. They're usually gel caps and very easy to take. And so I really strongly encourage supplementation for people who are concerned about their vitamin D, and I think we probably all should be. I don't like to recommend testing for everybody. That's really the only way you know, but that incurs cost, and so there's some pushback on encouraging everybody to have their vitamin D levels tested. But probably it's not out of line for everybody to be tested at least once during the winter so you kind of get a baseline. We get very little from food, and even if salmon is an excellent source, but it has to be ocean raised. I try to get ocean raised salmon in Omaha, and it's only about one place I can find it. Most of it is raised in lakes, and so it's very, very hard to get enough vitamin D from food. So I want to talk a little bit about menopause, which is a very important time for bone health in women, and we're ignoring something that's critical. This is a study that we did where we followed 75 women through menopause. We asked them to volunteer while they were still premenopausal and over the age of 45, and they had normal sex hormones. And then we followed them until a year after their last menstrual period. So we followed them through menopause. I always say I went through menopause with 75 women. It was kind of a group experience. So this shows their spine bone mineral density on average. So this is the average, and this 0 line accounts for menopause, which would be the last period in each of these people, which we were able to capture. So bone mass starts to decrease about 2 years before the last menstrual period, and it continues to decrease until about 4 years afterwards. And on average, at the spine, these women lost 10.5% of their bone mass. That's a lot. That could take them from healthy bone down to high risk. And some women lost as much as 20%, a fifth of their bone mass. So then and now I'm still railing about this. Why aren't we doing something here when people don't even know that they're losing bone mass? Clinicians who are on top of it say, well, this person went through menopause, now we have to worry about osteoporosis. Well, I think we have to try to address this. Now, the only way to detect osteoporosis before a fracture occurs is to do bone mineral density testing, and we use DEXA. It's very low radiation, takes about 15 minutes to do. We measure the density usually at the spine and the hip. And Medicare will cover it. I'll show you some of the coding, the guidelines, and insurance usually covers it if you have a risk factor. And these are reported with T-scores, and a T-score is basically a standard deviation. And so what we set as the normal is what this yellow line represents is the bone mass in a woman. And this is age 30, 40, 50. This is what happens on average to a woman's bone mass, sort of like I showed you in the earlier slide. So we call kind of baseline or normal for these T-scores the BMD at age 30. That's a little bit after peak. And then we compare everybody's bone mineral density to that density. And what we have here with the little X is a 60-year-old woman. Her DEXA showed that her bone mass is 3 standard deviations below that of a 30-year-old healthy woman, or as a T-score, it would be a -3. Now, the World Health Organization has defined what's healthy and what's not according to T-scores. So if you have normal bone, you would have -1 T-score or higher. If you have a -1 to -2.5, you're considered to have low bone mass or osteopenia, and that puts you at higher risk than normal. And if you have -2.5 or more, then you're at very high risk for having a fracture. And you can go in and have a 15-minute DEXA and you'll get this and more. I'll talk about that. However, if someone has a low trauma fracture, they have osteoporosis. They don't need to show osteoporosis on this. This is used to help detect osteoporosis in people who haven't had a fracture yet. We'll still do a DEXA on somebody who has a low trauma fracture because we want to follow them on treatment to see if their bone mass is responding. Another thing we use to report DEXA is something called FRAX, and we're using this more because what it does, it incorporates into this formula not only the bone mass and of course their sex and their age, we do that anyhow, but whether or not they've had a previous fracture, whether their parent had a fractured hip, whether they smoke, are on corticosteroids, whether they have rheumatoid arthritis, whether they have secondary osteoporosis, whether they drink alcohol more than 3 units a day. And all these are, we know, are high risk factors. So we're factoring in their other risk factors where the T-score doesn't do that. And this is kind of a busy slide, but the message here is you come up with a number for major osteoporotic fracture. If your number here is higher than 10, you're at risk, and how much higher designates how much greater your risk over the next 10 years. And for hip fracture, if you're over 3. So this woman, and it's not the same one we saw on the T-score, but this individual here would have a high risk of a major osteoporotic fracture as well as a high risk of having a hip fracture in the next 10 years. So when to do bone density testing? Now, Medicare guidelines recommend women 65 and older and men 70 and older. But in our unit for people on Medicare, we can usually get younger women, especially if they're in menopause or postmenopausal. And others, and insurance companies usually follow along. In fact, we get our most of our DEXAs paid for even for younger people who are on their own insurance. You just have to identify fractures, risk factors. So skipping periods, hot flashes, family history of osteoporosis or fracture, or their own personal having a fracture after the age of 50. So you have to kind of dig around for codes, but usually we can get them paid for, and they're not real expensive. It does depend on where you go. I think like at CHI Health, where I think we charge about $120 for one now. But again, so it might be worth it even if people have to pay out of pocket, but usually we can get them paid. These are risk factors I've kind of alluded to, and ones that are pretty self-explanatory. So we talk about secondary causes of osteoporosis just briefly. The medications that do the most damage, we're all aware of steroid osteoporosis. Fortunately, most people are treated with lower doses now, but anybody who's been on long-term steroids probably has lower bone mass and architectural deterioration. In fact, for a while there was a practice of putting people on medications when they were started on corticosteroids, and I'm not sure where that's at now. I don't think that's common. Antidepressants have been shown in many studies to decrease bone mass, and we have what, 50% of the U.S. population on antidepressants, so that's something to be aware of and to teach your patients. Anti-seizure meds, and that both the corticosteroids and anti-seizure work probably in more ways than one because they also affect vitamin D, but they do affect bone cells. And then disorders that contribute to fracture. Diabetes is a big one. There's a lot of research being done on fractures in both type 1 and type 2 diabetics and trying to figure out the mechanisms. It might be accumulation of AGEs, but there's still a lot unknown. And of course, these people are having low trauma fractures at a younger age, but they also need to be treated. So I think there's kind of in the back of your mind, watch out for diabetics and their bone health and talk to them about it. And if there's concern or you have concern, they should be referred for DEXA. And then the malabsorption syndromes. We find patients not infrequently who have very low bone mass, and when we work them up, we found out they have a gluten enteropathy and they don't realize it. Now, people are more gluten aware now than they used to be, so maybe that isn't a surprise so often anymore, but that's one cause. Also, bariatric surgery. We have people who have a lot of risk of osteoporosis and also rheumatoid arthritis. So everybody, no matter whether their sex, their ethnic group, their racial group, especially adults over 50, are at risk of low trauma fractures. Now, we don't think of 50 as older adults, but commonly in some guidelines, a fracture, a low trauma fracture after 50 is probably an osteoporotic fracture, and 50-year-olds have a long time to go yet. And I'll show you some data that show they're at higher risk of another fracture. So I've just said what I've there. So, and I want to point out again that a trip fall, and you break a wrist, you break a hip, you break your ankle, unless the ankle was twisted in a real peculiar way, those are usually osteoporotic fractures. And again, it's very important to describe, you have to elicit and then describe to providers the circumstances of the fall. Now, compared to the expected fracture rates in the community in one study, the risk of a hip fracture following this forearm fracture was increased nearly 1.5 times in women and almost 3 times in men. So that if you can catch the wrist fracture, you might be able to prevent their hip fracture if you get them treated. Any fracture after age 50 increases the risk of hip fracture by 1.5 times. So we have a wonderful, wonderful armatorium of drugs. And I could do a whole workshop on that, so I'm just going to hit the high points. The bisphosphonates inhibit bone resorption, and we have some that are given orally, IV. I think those are the ones that we're using now, and they can be monthly. We have the IV one can be given once a year. Go in with your flu shot and get your, except the IV one takes really an infusion, not just a sub-Q. Then parathyroid hormone. It stimulates osteoblasts to build new bone, and we have 2 forms of that. That's only given for 2 years because there's a black box warning about in initial animal studies there was some risk of sarcoma. So that's never been shown in humans. We have a monoclonal rank ligand antibody, what's called denosumab. It's given every 6 months as a sub-Q injection. We have a new drug that's out. It's a monoclonal sclerostin antibody, and that stimulates osteoblasts to build new bone. And that one actually is shown to, most of the bisphosphonates in large clinical trials prevent about half of the fractures in people with low bone mass. But the new drug, romosozumab, actually has shown that it decreases fractures by 70%. So you can see if you can treat people, you have a great chance of preventing maybe even the first fracture, but for sure the second. Now, estrogen replacement is also something that can be used, especially in these perimenopausal women. Estrogen, if you take estrogen replacement and you start early enough, you prevent that menopausal-related bone mass. So that's something premenopausal women who are starting to have hot flashes could do. Now, for a while, everybody was getting estrogen, and then the Women's Health Initiative came out and said it caused breast cancer. Well, they never made as much publicity about the fact that they reanalyzed the data, and it did not increase the risk of breast cancer. So and most guidelines say it's safe to take estrogen for at least 5 years. So if a woman's not sure she wants to go on a drug to prevent osteoporosis at an early age, she may want to have her DEXA done, and if she's kind of low anyhow, she would want to avoid that 10 to 20% loss of bone around the time of menopause. because she's probably somewhere between 45 and 55 years of age. She has a long time to go yet. So that's something to consider. And then lastly, we have something around that's not used very much. It's a selective estrogen receptor modulator, which is called raloxifene. And it actually prevents fractures by about 50 to 60%. It's oral, and it also has been shown in large trials to decrease the risk of breast cancer. And it's just funny that they're not selling it like candy at a candy store, but the problem is the side effect is an increased risk of clotting. So it's not used real commonly, but it's available. So another thing that isn't talked about a whole lot, but it's a real practical way, especially for skinnier people who are at risk of fracture, are these hip protectors. They're polyethylene cups, and they fit inside an undergarment, and the cups hit over the head of the trochanter so that when the individual falls, and older adults have been shown in studies, they fall to the side rather than forward. I'm not sure the mechanism of that. Maybe it's that balance thing. But they fall to the side and they hit the head of the trochanter and they have a broken bone. So this fits over that trochanter and disseminates the impact of the fall. I wore a pair of these for a day under a pair of slacks to see if anybody would notice, and my colleagues are very open if my hair is a different color, so they'd have told me if I was getting big hips. And nobody said anything until I started rapping on it, and they thought it was funny I had a plastic sound. And they are really, it was very comfortable too. It'd probably be a little warm in the summer, but it's something to consider, especially for those skinny people who have absolutely no padding over their hips. And there are data to support this. This was a data from a study in which they looked at 1,800 people over the age of 70, and all of them were up and around, and they had at least one risk factor for hip fracture, and then they randomly assigned them to wear either the hip pads or not. And so they reduced the risk of hip fracture in that cohort by about 66%. So they prevented 2/3 of the hip fractures. So, and there are many different brands available. You can Google, you probably can get them at some of your local medical supply places. And I don't know, but you probably could get them paid by a third-party payer, because it's a lot cheaper to buy a pair of those. I think they're about $60, $70 compared to paying for a hip fracture, which is the price I'm told is about $65,000. So that's kind of easy. So this just shows the diagnosis and treatment of osteoporosis in women following a distal radius fracture. And so it shows that women who had a distal radius fracture in this study, only less than 3% got DEXA testing. This was done in 2000, so about 11% of them were given estrogen because they're younger women usually, and only about 3.5% there were put on some type of medication. So they're just being ignored. Now this shows the rates of initiating osteoporosis treatment after a hip fracture, and this is right off the press, published in JAMA in 2018. So it shows how many people who had an osteoporotic hip fracture were started on treatment by year. So we were doing fairly well in 2004. Even at that, it was about 9.5% of the people who were diagnosed with an osteoporotic hip fracture started on treatment. Till 2015, the last data collection, a little over 3% of these people with hip fractures were started on treatment. So, my question is, and I do have a bias, does osteoporosis suffer from ageism and sexism? Although treatment options are available that could prevent up to 70% of osteoporotic fractures, only 4 to 20% in some other studies of patients with osteoporotic hip fractures are treated. So I ask you, would that happen with hypertension? You go into your primary care clinician, blood pressure over 130 over 80, and maybe you should be on antihypertensives. Maybe that's stretching it, but it's not much, I know, because I'm told. And sure, we want to prevent strokes and heart attacks, but I'm hoping convincing you we have to do the same thing to prevent these osteoporotic fractures. Now, I ran across this article a few years ago, and I just went into orbit. So I'd like to show you the picture. This is a figure from a journal article that was published in the Journal of American Geriatric Society in 1963, and it shows a little old woman with her purse. And the figure legend says, this is a woman showing some of the stigmata of nature's defeminization, the general stiffness of muscle and ligaments, the dowager's hump, and the negativistic expression are part of a picture usually attributed to age alone. These women exist rather than live. And I thought, what in the world here? Well, it turns out the authors were a husband-wife team of OBGYNs, and this was in the 60s when estrogen replacement therapy was being encouraged. And I think what a message here is that they were trying to over-dramatize that these are natural parts of aging, and the dowager hump just is part of that aging. And I think, although that was the 60s, I think we still see that today, and I know we do because when we look at the data, these people aren't being treated or even identified. Also, it's a woman's disease, a little old lady's disease, and you know, I think there's still that's part of the issue. But frankly, I think men probably are ignored even more than women in this. So my call to action is, you know, just be alert. I think every one of you somewhere in your practice or in your own families and communities can do something to raise awareness and to let people know what is available to prevent fractures. Now, not only do we not recognize and detect osteoporosis and we don't treat it, but once we do treat people, adherence to the oral bisphosphonates is shown to be very low. And I just show one there have been many, many studies, but these are data from a recent systematic review of the literature. There were 89 studies. And they found that the mean adherence to oral bisphosphonates after 6 months was somewhere between 38 to 79%. After 1 year, 13 to 78%. And after 2 years, less than half of the individuals prescribed bisphosphonates were taking them. And there are studies that show like a third of people don't fill their prescription. And a recent study found that media reports contribute to the poor adherence. What the media is playing up, and I watch this very carefully, are the side effects. The side effects of bisphosphonates that are most notorious are osteonecrosis of the jaw and atypical fractures, which probably are due to long-term bisphosphonate use. But the data show those side effects are rare. And folks, every medicine, aspirin, every medicine has a side effect. And even osteonecrosis of the jaw can be treated, and probably it does not have as much morbidity, and it definitely not mortality as compared to hip fracture. So if you doubt me, look at the data and see the reports on incidence and morbidity of these side effects. There's much more mortality and morbidity associated with even wrist fractures and vertebral fractures. Now I want to talk just a little about fracture liaison services, but Chris told me that there's an initiative here to get it started, so I'm just excited. If you can support her and help her in any way, do this, because this is wonderful service that different agencies and clinics in the country are doing. And what it's defined as is a coordinator-based secondary fracture prevention services implemented by these healthcare systems for treatment of osteoporotic fracture patients. They're going to try to close that care gap and catch people and patients who have fractures. So in this service, individuals in the hospital with an osteoporotic fracture would be identified and then set up for referral and treatment. Because, as I point out, these hip fracture patients that aren't being treated, most of them had their surgery in a hospital. Somebody should have said, duh. So I can't say enough about how good that is. And I'm not going to take too much time to talk about it because I have a lot of content I know. And if it's starting here, all I can say that the key points of the service are having a dedicated coordinator who is usually a nurse. And again, nurses can make a great big difference in this. And if you're on the floors and you know that you have patients that are fractured, find out, talk to the provider, find out when you get your fracture liaison service up and running, and communicate that. There are so many resources available. Number one is the National Osteoporosis Foundation, NOF.org. They have everything for clinicians, for patients. They have PowerPoints you can download. They have handouts you can use. And the second, that's also at NOF.org. I've given the whole pathway, but you look for the clinician guide. They have a multi-page clinician guide that will address everything you need to know. Basically everything I've addressed here, plus in more detail, more about specific side effects of each medication, just on and on. I can't recommend that enough, and they have an app. You can download it to your mobile device. And then our osteoporosis.creighton.edu, we have information on there. And this is an amazing resource for any of you who are clinicians, or even if you're not actually prescribing but you're more interested. It's called Bone Health Tele-Echo. And it's put on as a weekly webinar, interactive, by Dr. Mike Lewicki, who's an osteoporosis expert in New Mexico, and it's every Tuesday from 12 to 1:15, but that's Mountain Time, so that would be 11, no, we'd be ahead. It'd be 1 to 2:15 here. And it's set up for clinicians to present cases. And even if you just want to hook on and listen, you don't have to have a case, but it's fascinating because there are a lot of nurse practitioners I see on there because they're out in rural areas and they really don't have any excellent resources, and so they bring their difficult cases. And it might be something some of your clinicians might even be interested in, because we're finding most osteoporosis today is treated by primary care, and primary care clinicians just can't be experts on everything. So even attending this once or twice would probably be real enlightening. Also, annually there's an amazing conference dedicated specifically to osteoporosis, all aspects, and it goes on usually for 4 days. And they also have training for the FLS program at that point. And in this year, registration is open. It's in La Jolla, so that sounds real good. That's sunny California. So I'm going to summarize. So osteoporosis is a public health problem that has grave consequences for individuals, families, and our nation. That sounds kind of up in the sky, but that's fact. And research evidence supports many interventions to build and maintain bone mass and quality. Low trauma fractures after the age of 50 are an obvious clue to underlying osteoporosis. So in all your dealings with people, be aware of what appear to be low trauma fractures. At the very least, make recommendations for BMD testing and further evaluation. You may have somebody who has a gluten enteropathy that doesn't know about it. So you might be addressing two problems. State-of-the-art screening is available to detect persons who are at high risk for osteoporosis and in whom treatment might be helpful and prevent them ever having a fracture. However, as I've said many times, osteoporosis is underdiagnosed and undertreated. Furthermore, adherence is poor in those who are given at least oral bisphosphonates. If you know that there are individuals who have problems with adherence, I'd sure consider the once-a-year IB. So in conclusion, there are a multitude of resources that are available to decrease the burden of osteoporosis in this country. And clinicians from every healthcare discipline really are needed to join in this effort. So interdisciplinary practice is a key term, and it's something we're recognizing as important. And this is an area that really is best served by interdisciplinary practice. So we need to educate our clients or patients about osteoporosis, and also be alert for those who have had what could be a fracture. Any patient who has risk factors should be referred for evaluation and treatment. And if we have people who are on treatment, we know that adherence is low with those, and so we want to make sure that we're following up with them. So this is Creighton in the spring, and I'm hoping we'll see blooming before too long. And I really thank you for your attention, and I'll stay during break if you have any questions.